Welcome to our CME and SDMS CME accredited ultrasound webinar, Intravenous Contrast Ultrasound Applications in Children. My name is Matt Wilson, representing the International Contrast Ultrasound Society, ICUS, in collaboration with Northwest Imaging Forms, the CME provider for this program, and Children's Hospital of Philadelphia, CHOP. Northwest Imaging Forms is accredited as a CME provider by the ACCME. Northwest Imaging Forms designates this CME activity for 2.5 Category 1 credits towards the Physician's Recognition Award of the American Medical Association. Sonographer SDMS CME is also provided for those wishing to receive up to 2 hours of credit Category PE. The planner of the CME activity has nothing to disclose. Please find the Q&A button on your screen's lower menu bar to readily ask questions of the faculty as you are listening to their respective presentations. They will respond to questions in the discussionary periods. It is now my privilege to introduce Casa Darje, MD, PhD, DTMNP, FAIUM, FSAR, Professor of Radiology and Surgery, Perelman School of Medicine, University of Pennsylvania, radiologist in chief, and the William Van Allen Endowed Chair, Department of Radiology, Children's Hospital of Philadelphia. Dr. Darje.
Thank you so much, Matt, for the introduction. It's really indeed a great pleasure for me to welcome all the participants. On behalf of the Center for Pediatric Contrast Ultrasound at Children's Hospital of Philadelphia, I want to say that we are very happy to collaborate with ICUS to present this dedicated session on IV use of contrast ultrasound agents in children. I am very grateful to all my colleagues who are participating in these presentations. With the approval of ultrasound contrast agents for pediatric use in the USA, there is significant advancement of its application in children. So today we want to share with you our experience at Children's Hospital of Philadelphia, where we have established a whole center for pediatric contrast ultrasound that supports clinical service, research, and education in pediatric contrast ultrasound. Without further delay, let me introduce the first speaker, who is Dr. Susan Back, who is the director of the Center for Pediatric Contrast Ultrasound, and who also holds the endowed chair for pediatric contrast ultrasound at Children's Hospital of Philadelphia. She's also the director of the section for genitourinary imaging. Just for your information, the co-director for the Center for Pediatric Contrast Ultrasound is our research sonographer, Trudy Morgan, who will be also participating in this webinar. So without further delay, I want to ask Dr. Back to take over and start with the first presentation. Thank you very much.
Thank you very much, Casa, for opening the day and introducing our program. Good day to everybody. We're going to start off our session today with a discussion about the technical aspects of contrast ultrasound applications in children. This will involve discussion of off-label use of the contrast agents. And what I'll do is I'll cover some of the technical aspects of the contrast ultrasound exam and try to highlight some ways that this modality can benefit our patients and work in some pearls and pitfalls to keep in mind while you're doing these exams. I'm going to focus on intra-abdominal applications because that is the largest part of our intravenous use, but as you'll hear from other team members today, that there are a wealth of ways that we can apply contrast imaging with an IV application in children. I won't have time to go into all of the detail about the basics of the microbubbles themselves, but I do want to refer you to this recent publication in pediatric radiology that's geared toward the imager to give you a better understanding of contrast agents. And I hope you'll explore this reference and some others that I'll mention for more information. Do keep in mind that the ultrasound contrast agents are pure vascular imaging agents. And so different from what we see with CT and MRI, where the contrast agents can enter into the tissue, the ultrasound contrast agents show us exactly where the blood is flowing. So I'll start with how we generate the contrast image. The ultrasound wave is essentially a pressure wave, which has positive and negative components. And when the ultrasound contrast microbubble is exposed to these waves, it will expand and compress. But the magnitude of the compression and expansion is different. There's a shift. And so this non-linear response that the microbubble has to the ultrasound signal is different from that of tissues in the body, which typically have a linear response to ultrasound. And so because these responses are different, we can subtract out the signal that the ultrasound contrast agent sends to the ultrasound machine. And by way of doing that, we can see where the blood is flowing. So here's an example of the right kidney where I have a dual display image with the grayscale reference image. And then the orange image is a contrast only depiction, which shows that subtraction of the microbubble signal from the grayscale. When we go into contrast mode, the benefit is that we want to change the ultrasound settings so that it prolongs the microbubble life or time span so that we can get the images that we need. So it will automatically adjust the mechanical index. We'll talk about how we can adjust the gain. There are additional adjustments that you may choose to do to optimize your image quality, much like you would for grayscale image. We'll also want to keep in mind which probe we're selecting and how we position that probe on the child. The mechanical index is a mathematical estimation of the acoustic pressure in tissues. It's not the same between all ultrasound vendors, but is usually displayed somewhere on the image. So all contrast imaging at this point is a low mechanical index to preserve the life of the microbubble. If you increase that mechanical index, then that will facilitate faster microbubble destruction. There may be some times clinically where you do need to adjust the MI. So for example, if you are approaching a deeper lesion within the abdomen, or in clinical scenarios where it's more difficult to penetrate the tissue, such as in steatosis or cirrhosis, you may opt to increase the MI slightly. And you may actually choose to decrease the MI if you're focused on a more superficial body part or lesion. The gain we're going to adjust similar to how we would within grayscale imaging, but most vendors allow the imager to independently adjust the gain of the contrast display versus the grayscale reference image. And so you want to turn the gain down until it's just above the background for noise. And so you see on this contrast only image, this is prior to contrast administration, that we are able to subtract out most of the signal. However, there are some strong interfaces that will not suppress on this display, and those include things like organ interfaces. Here you can see the capsule of the liver and the kidney, and perhaps if you had bowel gas, that those areas would not suppress. But those could be beneficial to you because they will give you your frame of reference for where you are in the body in the event that you don't have your grayscale reference image displayed as well. Once you set the gain on your pre-contrast imaging, you do want to leave that gain setting throughout the contrast administration. And you don't want to adjust it. And the reason being is in this example, so this was a 15-year-old boy who had a splenic lesion. He did have a prior renal transplant and had known post-transplant lymphoproliferative disease. So we were focused on the splenic lesion, and we did image the entire exam at a gain of 40. But you can see as we adjust the gain, if you were to turn it down or turn it up, you change the sound that you're seeing. You change the echotexture of what you're seeing in the central aspect of the lesion. And so if you make this manipulation while you're administering contrast, it will cloud your interpretation because it will be unclear about whether there was wash-in or enhancement in the central aspect of the lesion. So once you set the gain on your pre-contrast images, you want to leave it for the one injection. And if you need to make an adjustment, you can do so on a subsequent contrast administration. You're going to select a probe for contrast much in the same way as you would consider for diagnostic imaging. You want to consider the body habitus and the region of interest. For this 2-year-old boy, we were focused on a more superficial liver lesion, which we were following up. But during the course of the examination, we were sweeping through the liver to see if there were any additional lesions. And you can see with these current settings that we were having difficulty visualizing the deeper part of the right hepatic lobe. So in order to go about imaging this area, we had some options. We could either adjust the frequency within the transducer that we are already using. You certainly could switch over to a different probe if needed. We could also reposition the probe, so move more in a coronal plane to get onto this posterior aspect of the liver, or perhaps our last move would be to increase the MI slightly to get better signal from the deeper tissue. The goal is also to always have the probe as close to the area of interest as possible. Here we are evaluating a 15-year-old girl who had pyelonephritis with a question about whether there was an abscess in this area of infection. When she was in a supine position, the best we could get for the probe to be close to the kidney was close to 9 centimeters. So we did have her turn into the prone position where we could bring the area and the kidney closer to the probe. And you can see here in her upper lobe, upper pole of this right kidney, there's an area of persistent non-enhancement, and that was consistent with a small abscess in the area of known pyelonephritis. For most of our examinations, there is not a specific preparation required on the part of the patient. If you're doing targeted imaging of the bowel, you may ask that the patient refrain from eating to help decrease bowel peristalsis. And if you're looking at the gallbladder, you want them to refrain from eating to distend the gallbladder itself. Patients come to us with a full bladder if we're evaluating the bladder or the bladder wall, or if we're using the bladder as a sonographic window to see the deeper pelvic structures. Certainly a benefit of contrast ultrasound, just as ultrasound itself allows our patients to be in a flexible position, which is really helpful when a child needs comfort from their caregiver. So children can be held by their parent, they can be in an upright position or supine. We don't require any specific breathing pattern for the child, and actually hope that they will be calm and have a quiet, shallow respiration, because breath holds may not be possible based on their age or their development, but you have to work with the child and the family to get the best window and to keep them as calm as possible during the test. We do perform these examinations both through peripheral and central lines. If we have the preference and we're placing the IV for the purpose of the exam, we try to place it on the patient's left side so that this person who is doing the ultrasound imaging can be on the patient's right side. We attach the 3-way stopcock so the contrast agent can go in line or in the 180-degree port of the stopcock to minimize any turbulence or destruction of the microbubble agent as it's administered, and attach the flush at the 90-degree port. In pediatrics, we're accustomed to using smaller gauge IVs and very commonly use 22 and 24 gauge IVs. We have on occasion used a 25 gauge IV, but can experience some loss of contrast signal because the bubbles can be destroyed going through the smaller gauges. So we try to be above 24 gauge if possible. There are 3 commercial agents that are currently available in the United States, only one of which, Lumasan, the present time has FDA approval for administration for children. I've included here the package label dosing. There's a maximum dose per injection of 2.4 milliliters for liver imaging and a maximum up to 2 milliliters when used for echocardiography. Of course, Lumasan also does have indication for intravesical administration for vesicoureteral reflux, but that is not the topic of today's discussion. Optison has in the literature pediatric dose information, and at this point in time, Definity does not have any specific pediatric dosing reported. The doses that I've just presented are probably going to be successful for most of the applications in the abdomen. However, you do have to keep in mind that you may need to optimize based on your ultrasound unit and whichever contrast agent you're using. The things to keep in mind that will affect whether you need to adjust either dose or imaging parameters will be the sensitivity of the software on your ultrasound unit, the indication, whether you're imaging something that's highly vascular or whether it's something that tends to get less blood flow or is deeply located within the body. Depending on which frequency you need to image with, you might have to adjust the dose, and that will also play into the patient's body size and habitus, and as well the caliber of the IV, noting that if you're using very tiny caliber catheter, you may have some contrast loss at the time of administration. Why would we choose to use contrast for children and within the abdomen? Well, it shares many of the benefits of ultrasound itself without radiation, not needing to sedate children. It's a safe application, which you'll hear shortly from one of our colleagues. We can perform these examinations at the bedside. We can travel to intensive care units, potentially into the emergency department. It allows the real-time observation of blood flow, which gives a temporal resolution, which is superior to CT and MRI imaging. And it helps us see the blood flow in vessels that are smaller than that of what we can see by Doppler. There are some reasons why you might choose not to use ultrasound contrast, and those relate to whether you can see the area of interest. So, for example, if you have a child who has quite significant scoliosis, it may be very difficult to get adequate visualization of the kidney. And so in that case, contrast ultrasound may not be the optimal examination. Also, if your goal, especially in the setting of trauma, is to see excretion of contrast from the kidney, this may be a relative limitation. So you may use contrast ultrasound as a complementary imaging examination, or it may have a subsequent exam may need to follow contrast depending on what you see on the ultrasound examination. If you're using just one ultrasound unit at a time, then you have the limitation of seeing one body area or region. So if you have numerous lesions in different organs that you need to assess, you may consider a different modality. But these are all relative contraindications, and certainly contrast can have a role in these clinical examples as well. Our goals in our department are to use ultrasound contrast as a diagnostic tool. So we'd like to replace the use of CT and MRI when possible. We also do use it as a tool to triage or to screen, and then in some clinical scenarios to do exam follow-up. Consider for a moment these two patients, both with Beckwith-Wiedemann syndrome. These children have a higher risk and likelihood of developing tumors in the abdomen, and one of which is a hepatoblastoma. These were two children who undergo routine imaging surveillance as part of a clinical protocol for children with this syndrome. And for both of these children, we identified on these days focal liver lesions. So the question from here is, where do we go? Do we need a different imaging modality? Do we need to biopsy? For each of them, we chose to go to contrast ultrasound next. And you'll see in the first few seconds of contrast enhancement for each child, there is hyperenhancement of the lesion. When we continued to watch the lesion in the little girl, there was washout from the central aspect of the lesion, while the delayed images of the little boy, we see that the lesion has sustained contrast enhancement. So based on these imaging patterns, we were more concerned that the little girl had a tumor that was consistent with hepatoblastoma, while the boy had a more benign appearance of his lesion. And with confirmation with tumor markers and follow-up imaging, these diagnoses were confirmed. We have two general approaches to lesions and intravenous exams in the abdomen. If we're looking for a focal lesion, we do want to focus on that area while contrast washes into the body. We're going to have the probe as close to the lesion as possible. We want to keep normal organ parenchyma in the field of use so that we can see how the area of interest enhances relative to that normal area. And we're going to watch until contrast washes out. So we're going to record the first 60 to 90 seconds on a cine loop, and then we're going to look intermittently until contrast washes out of the background organ. From the cine loop, we can then save representative static images so that we can depict the different time points that will support our interpretation. For focal liver lesions or other focal lesions in the abdomen, it is best if a second or subsequent administration of contrast is needed to allow the contrast to dissipate so that you get a better understanding of the wash-in of the contrast agent. You can then save the static images from your cine loop. And these will show how the contrast has been within the lesion over the course of the examination. When we're doing general image surveillance, either for a lesion or trauma or perfusion, we use gentle sweeps through the organ or region of interest. This is a normal examination of the liver in a 17-year-old boy who was in a motor vehicle collision. If we need to evaluate multiple organs at the same examination, you have to consider the order in which those organs will enhance so that you can visualize all of them in the same time. Typically, in an exam such as trauma, we can image the entire abdomen with 2 injections. And different from our focal lesion assessment, injections can be repeated, but we don't need contrast to dissipate in its entirety for the examination. So when we work within the abdomen, this is the relative order of organs. When we start with the pancreas, which enhances first and peaks very early, this is a normal examination of the pancreas in an infant who had blunt abdominal trauma. We then would move on to either the right or the left kidney. There are 3 phases of contrast enhancement described for the kidney: the cortical phase, where the cortex enhances above and greater than the medullary pyramids; a second phase where the cortex and the medullary pyramids enhance to a similar extent; and then a delayed or washout phase, again noting there's no excretory phase. The adrenal glands will enhance in a similar time frame to the kidneys. The liver and spleen enhance, have a sustained parenchymal enhancement phase, which is latest. And so, for example, in the setting of trauma, while we may see portions of the arterial and portal venous phase, we're going to focus on the late phase to see any disruption of the blood flow within the liver to evaluate for traumatic injury. And this was a normal liver in this 17-year-old boy. And the spleen also has an earlier phase of arterial enhancement and then a much longer delayed parenchymal phase, which is optimal time to identify trauma, but this was a normal spleen. So just to finish up with some pearls about these specific organs, when you're evaluating a focal liver lesion or lesion within the parenchyma, you want to keep in your field of view normal adjacent parenchyma. And this 19-year-old man with Lee-Fraumeni, he had a focal liver lesion, which was hyperenhancing in the arterial phase, and by 2 minutes had dissipation of contrast. This pattern makes us concerned for a malignant pattern. We know that metastatic disease will wash out from the liver even faster than hepatocellular type tumors, although HCC is much less common in children as it is in adults. There are rarely benign lesions which can have this pattern, and reported lesions that can do that are an infantile hemangioma or infectious or inflammatory lesions. But hopefully the clinical scenario and other supporting information about the patient will help you take the necessary next steps based on what you see on contrast imaging. And again, it's very important because some tumors do have a delayed washout phase, that you do watch the lesion until the background organ has washout of contrast. Just coming back to the idea of when to look at an organ. So here's an example of a 6-year-old boy that does have a splenic laceration. When we look at the spleen in the early arterial phase of contrast, we see that tigroid enhancement pattern, which we are familiar with from other types of imaging. And we don't want to mistake those areas for abnormality. So when we look at the spleen in a more delayed contrast phase, this is in the parenchymal phase, when the rest of the spleen should have a more homogeneous appearance, we still see that jagged geometric disruption of the contrast pattern in the spleen, and that is consistent with a laceration. Because the contrast agent is not excreted by the kidney, we can't assess the renal collecting system. So for this 5-year-old girl who we see has a splenic laceration and a perinephric hematoma denoted by the star, we can't delineate whether that is hematoma or whether there is extravasation from the collecting system. When you have knowledge about how an organ should enhance, it can also help you delineate pseudolesions. So in the kidney, this 11-year-old girl was referred because she had a hypoattenuating lesion on CT. When we brought her to ultrasound, this region had a similar echotexture to the adjacent medullary pyramid. But being able to then inject with contrast, we could prove our hypothesis that this was a medullary pyramid, because we see the cortex enhance, followed by the medullary pyramid, which enhances from an outer to central portion. It has a period of sustained enhancement and gradual washout. And so we felt more confident diagnosing this as a pseudo lesion than we did on CT. So in summary, we've gone through some of the technical principles of contrast ultrasound and discussed, hopefully shown you some of the ways that it is beneficial for the pediatric population, and highlighted some pearls and pitfalls. For reference, this recent issue of Pediatric Radiology is dedicated entirely to contrast ultrasound in children, and will go into more detail in many of the things I touched on and what some of my colleagues will talk about shortly. So thank you very much for your attention.
Thank you, Dr. Back, for your informative talk. Does anyone have any questions? Please remember to put them in the question and answer box. While we're waiting to see if we have any questions, we'll go over a few questions that we have been asked before. One of the questions was, when you're doing a contrast study, do you always see the abnormality in grayscale before you do the contrast, especially in trauma?
That's a great question. I think for trauma, not necessarily. You may have some findings that raise your suspicion, whether you have some free fluid or whether the child is sore or tender when you're in a certain area imaging on their abdomen. But we've been surprised by areas that are very subtle on grayscale. And maybe when we go back in retrospect, it becomes more apparent. But the contrast agent really highlights where an area of injury is.
Thank you. Also, is there a discrepancy between different manufacturers and how the bubbles relate in each manufacturer?
So I think depending on the ultrasound contrast agent that you're using and the ultrasound vendor, there are software specialists and the ultrasound contrast agent manufacturers can also have team members come support your program, your intravenous program, and help advise you on ultrasound parameters and settings, which help see those specific contrast agents optimally. And certainly you can phone a friend. I think anybody who is actively using contrast is more than happy to consult on what's been successful.
So we do have a couple questions. The first one is, in your experience, to differentiate between a hemangioendothelioma and a hepatoblastoma on CUS.
So we have done a handful of exams on lesions that ultimately are hepatoblastoma. I think just in my mind's eye and thinking about them, most of them followed sort of the typical pattern and had washout. We did have, I think that maybe the first one that we did was an incidental finding on a child who it was seen on grayscale. Child had a different examination. They saw a lesion, and then we went back with contrast. And I think we were in disbelief that it could be malignant, but it turned out to be malignant. The more benign lesions tend to enhance early and have sustained enhancement. You certainly can have atypical enhancement patterns of typical lesions. And so whenever there is a question, we do go on to MRI, or potentially, depending on the clinical scenario, you can do tumor markers or perhaps a biopsy if you really are unclear.
Okay, and the next question is, do you ever use two ultrasound machines simultaneously?
At the current time, we don't. I'm sure Dr. Dargay can bring us back to the times when he used to do that long ago, but not for intravenous exams at this point, and not in the clinical setting. We have not found that to be necessary.
Yeah, at the time in the mid-90s when we didn't have the second generation contrast ultrasound agents, which in the first generation were not so stable in the setting of trying to detect vesicourethral reflux in the kidneys. We actually used 3 ultrasound machines, and 3 people scanned separately the right kidney, the left kidney, and the bladder. Certainly something historical and not to be recommended, but now the bubbles are so stable that you don't need that. You can do everything with one machine. Thank you.
Okay, we'll have one more question. Is there any use for ultrasound contrast in detecting kidney stones?
So the kidney stones themselves do not enhance. For a diagnostic utility, I don't see one that is beneficial. I know we're focusing on intravenous applications today, but perhaps Dr. Vatsky might be able to talk a little bit later when he talks about IR applications, because there are roles to do direct access to the kidney. And perhaps if you were trying to use either intracavitary approach to fill the renal collecting system during placement of a percutaneous nephrostomy, or if you needed to enhance the kidney parenchyma to better identify a region of the kidney that during a procedure, perhaps. But in the diagnosis of renal stones, we don't use it.
Okay, thank you so much.
Thank you.
We're now going to move on to our next presentation. I'm going to invite Dr. Natulia to unmute her microphone and share her screen with us.
morning, everyone. So the topic of my presentation is about the safety of intravenous contrast-enhanced ultrasound in children. I have nothing to disclose. Contrast-enhanced ultrasound with second-generation ultrasound contrast agents is increasingly used in children. As a result, there is ongoing accumulation of safety data from the various clinical applications of ultrasound contrast agents and therefore better understanding of their safety profile. The purpose of this presentation is to provide an overview of safety-related information from the intravenous applications of ultrasound contrast agents in children, to present the frequency and type of adverse events that has been reported in pediatric literature, to discuss the contraindications of ultrasound contrast agents, and presents actions to minimize safety risks from their use. In 2016, the United States Food and Drug Administration approved the ultrasound contrast agent Lumason for 3 pediatric indications. 2 indications with intravenous administration for liver and echocardiography, and 1 intravesical application for detection of vesicoureteral reflux. Outside the United States, Lumason is marketed as Sonoview and has been approved in Europe and China only for intravesical applications at the moment. The other 2 currently available contrast agents, Optison and Definity, have not yet been approved for a pediatric indication, but they have been used off-label in children. The ultrasound contrast agents consist of tiny bubbles of gas stabilized within a thin outer shell. The gas determines the acoustic properties of the microbubbles in response to the sound waves. In other words, how bright the bubbles will appear. The outer shell mainly influences the stability and durability of the bubbles when stress forces are applied. For example, when bubbles pass through the pulmonary capillaries. The combination of gas and shell materials differs depending on the brand of contrast agent. The gas, which can be sulfur hexafluoride or perfluorine, has high molecular weight and low solubility in blood and water, and therefore it is biologically inert. The stabilizing outer shell is composed of phospholipids or proteins, which are biodegradable materials. The diameter of a microbubble is smaller or equal to the size of red blood cells. That makes microbubbles small enough to circulate without being trapped in the capillaries, but also large enough to remain inside the blood vessels. When administered intravenously, microbubbles are first filtered by the pulmonary capillaries and then proceed into systemic circulation, where they can be detected for several minutes before they dissolve. When they dissolve, their gas diffuses out of the shell and is exhaled intact via the lungs, and the shell components are cleared by the liver. Ultrasound contrast agents are not excreted by the kidneys, and therefore they are not nephrotoxic, and they can be safely used even in patients with renal impairment without the need for laboratory tests prior to administration. Moreover, CIUS exams usually do not require sedation and can be performed in various settings, including inpatient, outpatient, in the emergency department, at the bedside, and intraoperative. Ultrasound contrast agents are generally well tolerated and have a very good safety record. The only serious adverse reaction from their use is anaphylactic reaction, which is rare but can occur and has been reported in adults and children. In November 2021, supplement issue of Pediatric Radiology Journal, which is dedicated on pediatric contrast ultrasound, we published a review article about the safety of ultrasound contrast agents in children. In this article, in order to estimate the frequency of adverse events from the use of ultrasound contrast agents that has been reported in pediatric literature from the beginning of their marketing back in 2001 until 2021, we performed a literature review and we identified all original research studies during this 20 years post-marketing time period that were performed in pediatric-only cohorts with the use of the 3 second-generation ultrasound contrast agents, Sonoview, Lumason, Optison, and Definity. As of August 2021, a total of 57 studies have been published, including 4,518 children who underwent 4,906 intravenous exams. Among the 57 studies, 51 were conducted with Sonoview Lumason, including the majority of children. Of the remaining studies, 5 were conducted with Optison and 1 with Definity and included small size cohorts. Serious adverse events were reported in 10 children. All of them received intravenous Sonoview Lumason. So the overall incidence of serious adverse events reported in the pediatric literature is 0.22%. The 10 serious adverse events were reported as 4 cases of anaphylaxis, 3 cases of severe hypersensitivity reaction, and 3 acute episodes of hypotension with or without other symptoms. All 10 cases occurred at the time of injection or shortly after and required immediate resuscitation, including intramuscular injection of epinephrine, intravenous fluid administration, management of respiratory distress, and second-line medications were indicated. In all 10 cases, symptoms resolved completely with no fatalities reported. The fact that most of these reactions were anaphylactic or hypersensitivity reactions warrants a brief discussion on these definitions. Hypersensitivity is a broad term that refers to an overreaction of the immune system, which is initiated by exposure to a stimulus at a dose that should be tolerated by normal subjects. The original Gell and Coombs classification categorizes hypersensitivity reactions into 4 subtypes according to the mechanism of cell response. The first 3 types are considered immediate onset hypersensitivity reactions because they occur within 24 hours, and the 4th type is considered late onset hypersensitivity reaction. The most serious form of immediate onset hypersensitivity reaction is anaphylaxis, which is a medical emergency and is defined as a serious and potentially life-threatening reaction which has a rapid onset of symptoms after exposure to a provoking agent and which can affect multiple organ systems, including the skin and mucosal tissues with symptoms such as generalized hives, itching, flushing, swollen lips, tongue, and uvula, the respiratory system with shortness of breath, wheeze, cough, stridor, and hypoxemia, cardiovascular involvement with hypotonia or collapse, or gastrointestinal symptoms such as crampy abdominal pain and vomiting. In infants and children, anaphylaxis can present as episode of severe hypotension. Therefore, the 3 types of serious adverse events described in pediatric literature, hypersensitivity, anaphylaxis, and hypotension, are all part of the same spectrum of anaphylactic reactions. Regarding the non-serious adverse events from the intravenous use of contrast agents, these were reported in 54 children and occurred with all 3 contrast agents. Thus, the overall incidence of non-serious adverse events reported in pediatric literature is 1.2%. Following Sonoview Lumason intravenous administration, 31 children developed 47 symptoms. 43 of these symptoms were acute and occurred during or immediately after the injection. The majority of acute symptoms were mild skin reactions followed by taste alteration, nausea, and abdominal stomach pain, and less frequently by other symptoms such as tachycardia, hypotension, hyperventilation, stupor-like reaction, or other symptoms such as shortness of breath, dizziness, chest pain, fatigue, headache, hypertension, vomiting, chills, conjunctival injection, and cough. 4 symptoms were subacute and took place within 1 hour after injection. These were headache, hypertension, tachycardia, and hypotension. All symptoms resolved completely, with some of them requiring minor medical support. With Optizone and Definity, a few non-serious adverse events were reported, and these were similar in nature to what reported with Lumason, as seen in these 2 tables here. Since serious adverse events, including anaphylaxis, may occur during intravenous use studies, pediatric radiologists and ultrasound staff involved in CUS examination should be alert and prepared to recognize and treat symptoms of anaphylaxis. To facilitate immediate management, a resuscitation card should be in the vicinity of the ultrasound units where CUS examinations are performed. Regarding the contraindications, the only current contraindication of all ultrasound contrast agents is known or suspected allergy related to the specific composition of each ultrasound contrast agent. Therefore, ultrasound staff should be aware of the composition of the particular contrast agent that used in their department and should review allergies with patient and caretakers prior to the exam. In April 2021, the FDA requested the revision of the package labeling for Lumason and Definity to explicitly state that these 2 contrast agents are contraindicated in patients with known or suspected allergy to polyethylene glycol, known as PEG. And what is PEG? PEG is a group of polyether compounds that can be found as active or inactive components in many medical, cosmetic, household, industrial, and food products. PEG are active components in some bowel preparations and laxative, and inactive components in the shell of Lumason Sonoview and Definity. At present time, documented allergy to PEG is rare, but may occur in patients who have not previously received PEG, and this may be attributed exactly to the common use of PEGs in many everyday products. Therefore, before CUS exam, known allergies, including allergies to bowel preparations and laxatives, should be carefully reviewed. In 2016, the FDA removed from the package insert the previous contraindication for the use of ultrasound contrast agents in patients with known or suspected cardiac shunts. The rationale for this previous contraindication was based on the theoretical risk that microbubbles could pass from the venous system via the shunt directly into the arterial system without filtration by the lungs, with a potential for ischemic events. These initial safety concerns were based on research data from animal models, the assumption that ultrasound contrast agents have similar properties to macroaggregated albumin microspheres, which is a different radioactive nuclear imaging agent and contains a section in the package insert recommending caution in patients with cardiac shunts, but it is not contraindicated. In fact, it is widely used in these populations, and also on reports of serious adverse events that occurred in adults during the early years of ultrasound contrast agents. However, these events were not definitely attributed to ultrasound contrast agents, and some were later ascribed to underlying medical conditions or other medications. Subsequently, an exhaustive review of the literature demonstrated the lack of scientific evidence for this contraindication, and in 2016, the FDA removed the cardiac shunt contraindication from the label of all ultrasound contrast agents. However, a black box warning for possible severe cardiopulmonary events still remains in place. And since 2018, there is an ongoing citizens petition, which is supported by ICUS and has been submitted to FDA requesting removal of this black box warning. Summarizing this presentation, the use of ultrasound contrast agents in children is well tolerated. Serious adverse events from the intravenous use are rare. They have been reported in 0.22% of children in pediatric literature and present as anaphylactic reactions. Non-serious adverse events have been reported in 1.2% of children in pediatric literature and mainly present as mild skin reactions and gastrointestinal symptoms. Standard, safeguard, and medical precautions, including the presence of a code card near the ultrasound department, should be in place. And the only current contraindication is known or suspected allergy to the specific components of the ultrasound contrast agents, and also allergy to PEG for the agents Lumason and Definity. Overall, the high safety profile of ultrasound contrast agents combined with all other benefits of performing ultrasound in children is a driver for the wider applications of contrast ultrasound where medically appropriate. Thank you very much for your attention.
Thank you, Dr. Ntulia, for that outstanding talk. Please remember to enter any questions you might have into the Q&A section of Zoom, and we will review them. While we're waiting for other questions, Dr. Ntulia, have you in your clinical experience observed or experienced a patient to have a reaction?
Mild reactions such as skin reactions and symptoms like taste alteration or metallic taste, yes, I have seen, but I have not encountered a serious anaphylactic adverse reaction.
Okay. Can you speak to the way that the institutions you've worked in screen patients ahead of doing contrast ultrasound? Screen them for risk of reactions?
Yes, so before CIUS exams, there's a discussion with the patient or caretakers about known allergies, suspected allergies, any type of allergies. And since the revision of the package insert, a discussion about allergies to bowel preparations and laxatives is now included. So standard discussion about allergies.
Does your institution require consent for patients to receive intravenous contrast agents?
If it is for IV use and outside the US, yes, it requires verbal consent after discussion of risks and benefits. If it is for liver indication, no consent is required.
Okay, thank you. There is a question within the Q&A section. I'll read that to you now. It says, just a reminder, the contraindication for blood and blood products stated for Opticin has been removed. Thank you for that comment. Another question here is, what types of protocols have you developed at your facility and training? Have you seen success with in response to potential adverse effects to grow your contrast program? So I think that's an excellent question, I think, in light of especially the concerns raised about PEG and potential caution that people took after hearing that association. Although I think we've discussed that it's always been a component of the contrast agent. So I'd love to hear from you, Dr. Ntulia, about things that you've done to reassure folks or to re-educate people about contrast agents and use in your institution.
Yes, so as stated, the allergy to PEG is not a new contraindication. As we know, PEG is a component, inactive component of the shell of the sonofluomason end affinity. But with the recent revise, it has become more clear, like more specific. So that's why it is included in the discussion. Of course, the presence of the resuscitation cart near the ultrasound units where serious exams take place, this is a change in practice of ultrasound. And that's people who performed ultrasound scans, like sonographers, pediatric radiologists, ultrasound staff, should be trained to recognize and manage the main symptoms and signs of anaphylaxis.
Thank you. The next question is, does a physician have to be the drug administrator? Can the sonographer or nurse administer?
That, I think, it depends on the institution. If sonographers, usually if the institution has a combination of sonographers and pediatric radiologists, usually the pediatric radiologist is present at the beginning of the scan, during the injection, supervise the scan, and of course can also administer the injection. But this is something that it depends on an institutional basis. But in my experience, the pediatric radiologist should be present at the beginning, at least at the beginning of the injection, and to supervise the scan.
Just to add to what you've said, I agree with everything you've said. When we introduced it into our department, we let it mirror what we were doing in CT and MRI. And in those modalities, we have technologists who administer contrast. So our sonographers did undergo training for IV access and how to administer it. We do have an institutional requirement that if a central line is being used, that a physician or a nurse administer agents and medications through a central line. So in that clinical scenario, it has to be a physician or a nurse, but otherwise our sonographers at our institution are actively involved with contrast administration. Okay, well, thank you very much for that excellent review of safety.
Okay.
All right, if there are no other questions at this time, then I would like to invite Dr. Dennis to unmute her microphone and share her screen to discuss hepatic contrast ultrasound in children.
Good morning, everybody. Okay, so I'm Rebecca Dennis, and I'm a pediatric radiologist at CHOP. And today we're going to go over hepatic contrast enhanced ultrasound in children, specifically evaluation of focal liver lesions. First, I have no personal disclosures. I do want to reiterate that Lumason is FDA approved for intravenous use for focal liver lesions in children. Optison intravenous use in pediatric patients is off-label. For today, the objectives are we're going to review technique for performing IV contrast enhanced ultrasound to evaluate for liver lesions, as well as the different enhancement patterns. So focal liver lesions in the pediatric population, ultrasound is typically the first line of imaging for any suspected liver process, especially in children. Grayscale and color Doppler is usually nonspecific for focal lesions in the liver. You know, usually they're heterogeneous. They could be hypoechoic or hyperechoic, but it's really hard to kind of guide the clinicians for treatment or narrow down the differential. So if you see a liver lesion, a lot of times MR is recommended, but that can be really difficult in children and it can be costly. And then with contrast enhanced ultrasound, it can aid in like the workup as well as the diagnosis in children, as well as whether there needs to be follow-up and just kind of the overall clinical plan. As my colleague mentioned earlier, there was a special issue in pediatric radiology involving contrast enhanced ultrasound in children. There's an article going over benign and malignant liver lesions that is really helpful, and I would recommend using as a reference. So general indications for contrast-enhanced ultrasound of focal liver lesions. The main indication is characterization of an indeterminate liver lesion, whether it's incidental or found on surveillance imaging. It's also good as a problem-solving tool in cases where MRI or CT are inconclusive or technically limited. It's also helpful for follow-up of known liver lesions or follow-up after a baseline MRI. So there are many advantages as well as a few limitations for contrast-enhanced ultrasound of evaluating the liver. For advantages, of course, there's no radiation. Imaging conditions is really big, especially in children. It can be done in the ultrasound department. Parents can be present, child life can be present, with an iPad, help distract the patient. It also can be done portably, which is really important for patient condition. If there's something that needs to be evaluated and the child is in the ICU, we don't have to bring them down to the department and try to reposition them. We can try to get the best window possible. So that is really beneficial. It's also typically a shorter exam. There's no sedation required and no nephrotoxicity. And it's usually, and it's definitely more cost effective. For limitations, you can have limited visibility with patient size. So larger patients, just like in adults, you can have limited visibility. And it's also operator dependent, and it requires not only the sonographer to have training and education, but also the interpreting radiologist. For preparation and workflow, there's no patient preparation to evaluate for the liver. There's no sedation, no blood work. For the workflow, what we do is we scan the patient first. We ensure that we can see the liver lesion and make sure it's visible. And if it is seen, then we'll have the patient get the IV. We prefer not to have the patient get an IV ahead of time, just in case we can't evaluate a liver lesion, especially if it was seen on MR or some other imaging, just to prevent a child getting an unnecessary IV. For pre-contrast ultrasound, just doing conventional grayscale and color Doppler exam of the liver and to localize a lesion on the grayscale. You may need to encourage the patient to shallow breathe or depending on the lesion location, but sometimes that's not always possible, especially based off of the age of the patient. And a lot of times they're not able to breath hold. So for setup, contrast, what Dr. Back kind of already went over, so I'll just go over it very briefly. We recommend a 24 gauge or larger. Contrast dosing for Lumazon, since that's the one that is FDA approved for pediatric liver imaging. It's 0.03 mLs per kilogram with a max of 2.4 mLs per injection and a max total dose of 4.8 mLs. We recommend flushing after administering the contrast. And then you can do a separate injection if there's more than one lesion or you need further evaluation. You just have to ensure that the parenchyma, the contrast is completely washed out of the parenchyma before the second injection. For ultrasound parameters, typically we recommend to do a curved transducer, and that's for most infants and smaller children. If there's a larger child or an older child, lower frequency may be needed. Sometimes smaller or more superficial lesions, you might only be able to see on a higher frequency linear transducer, so that could be helpful. But don't forget that higher frequencies equals increase in bubble destruction. So you want to use that sparingly, especially if you can see it on a curved probe. You want to make sure you have a low mechanical index. And you'll use a dual screen mode with a low MI and grayscale on one side and contrast images on the other. You want to make sure that you have the same parameters. So if there is follow-up, that the parameters can be easily replicated or easy comparison. So for acquisition, after injection, you need to take a cine loop of the first 60 seconds with focus on the lesion. And you want to do that 60 seconds to ensure you get the arterial and venous phase. And you can even go a little after 60 seconds to get the full, portal venous phase. And you want to start your cine clip right after injection so you can get early arterial enhancement window as well. Then you want to take intermittent static or cine images. You don't need to stay on the one lesion for a straight 5 minutes. If you stay on a lesion, sometimes that can increase bubble destruction as well. And then you want to continue until contrast washes out of the background parenchyma. And that's just to follow the full enhancement pattern of the lesion. That being said, if the lesion completely washes out of contrast, you don't need to wait 5 or 6 minutes because the lesion's already washed out. So timing the hepatic enhancement, the arterial phase is typically 10 to 20 seconds up to about 35 to 40 seconds. Portal venous phase is 30 to 45 seconds up to 120, and then late is greater than 120 all the way up until 4 to 6 minutes. And then, as I said before, you want to avoid prolonged scanning of the lesion. It can cause bubble destruction, but also it can cause error in interpretation. So you can accidentally think early washout, but actually the bubbles are just getting destroyed from prolonged scanning. Next, we're going to go over interpretation. So for focal liver lesion interpretation, this is a chart from a radiographics article and going over the focal liver lesions in children. And this is a really good reference because it goes over common diagnoses and what to expect on each phase of contrast. What's really important is to compare the lesion to the hepatic parenchyma at the same level. You don't want to compare to the hepatic parenchyma deep or superficial to it. It needs to be at the same level to compare directly for each phase. So for case 1, this is a 6-month-old male with a PIK3CA mutation causing overgrowth. Focal lesion, liver lesion was seen on a whole body screening MR. So this is our screening MR. At CHOP for our screening MRs, we do T2 sequences and T1s. We usually don't do diffusion imaging, and we don't give contrast. So on this screening MR, there was a new T2 hyperintense lesion that's circled on the image. And the next step, we recommended an ultrasound to see if it's visible on ultrasound. And we see this hypocoque lesion that demonstrates internal vascular flow. And due to this patient's mutation and cancer predisposition, MR was actually recommended with EOVIS to further evaluate to exclude malignancy. So the MR with EOVIS on arterial phase shows this hyperenhancing lesion, same on venous, that it's still hyperenhancing to the background parenchyma. There's obviously some motion going on with respiratory, because obviously a 6-month-old can't hold their breath. And then on delayed phase, there is washout. So this is kind of indeterminate. We have it enhancing and hyperenhancing on arterial and venous, but it also washes out. So it could be malignancy, although that usually has early washout on venous phase. Could be an adenoma, it could be a hemangioma. So for further evaluation, contrast ultrasound was recommended. I'm going to play a cine clip from right after injection. So we see our hypocoque lesion. It's hyperenhancing on arterial phase. And now we're going to venous phase, and it is still hyperenhancing. And you can see it throughout. I have some still images. So on arterial phase, as we saw, there is hyperenhancement. On venous phase, it's still hyperenhancing to the background parenchyma at the same level. And on delayed phase, it's still hyperenhancing to the background parenchyma. So we go back to refer to our chart, and as we can see, hyperenhancement arterial, portal, venous, and late phase is compatible with a hemangioma. So this is a benign lesion. A companion case is a 39-day-old male with palpable liver. Patient got an ultrasound concern for hepatomegaly. See this heterogeneous mass with some increased echogenicity looking like calcifications, and it's very vascular. Patient got an MR, it's T2 bright, and on post-contrast arterial and venous phases, you can see it's peripherally enhancing and it's slowly filling in. So this is typical for hemangioma, and a contrast ultrasound was obtained, so a future follow-up could be done with ultrasound, so the patient wouldn't have to get continual MRs. And this is from the contrast enhanced ultrasound right after injection. This patient's 39 days old, so of course there's a lot of respiratory motion, and just like we saw on the MR, we have this peripherally enhancing lesion that slowly fills in. And this is compatible with a hemangioma. So case 2, 13-year-old male with epigastric pain presents for follow-up after an incidental liver lesion was seen on ultrasound. This was the ultrasound, it's a quite large, heterogeneous, predominantly hypoechoic mass with internal vascular flow. Contrast ultrasound was recommended for further evaluation. This is a video right after injection. So we see our lesion here. And as it fills in, you have the centrifugal hyperenhancement, kind of a spoke wheel pattern, and it still hyperenhances on venous phase. As you can see, still hyperenhancing to the adjacent parenchyma. From some still images on the arterial phase, to point out, here's the central of the lesion, and then you have like these linear hyperenhancing areas extending out. So that's the typical spoke wheel that we always hear or read about, and that we see on arterial phase. On venous phase, it is still hyperenhancing. And on delayed phase, we have central washout compatible with washout of a central scar. So this is focal nodular hyperplasia. This depicts the spoke wheel appearance. Sometimes you can just have it fill in the center, and you don't always have, of course, the nice spoke wheel. But sometimes you may see it. And then portal venous phase, it hyperenhances, and late phase, it can either remain hyperenhancing or be isoenhancing, but typically you'll see a central hypoenhancing scar. And so this is focal nodular hyperplasia. Next case is a 13-year-old presents with right upper quadrant pain and incidental liver lesion seen, and this is a follow-up for the liver lesion. On ultrasound, there's this 2.7 centimeter, well-defined ovoid hypoechoic mass that demonstrates a little bit of peripheral and central flow. Contrast ultrasound was recommended to evaluate. And this is a video from right after injection. So we see the lesion right here, and we have early hyperenhancement arterial phase. And then as we progress to venous phase, slightly hyperenhancing, but still, and then it's slowly becoming isoenhancing, but it is hyperenhancing on early venous phase. Some still lesions from after contrast administration. Once again, there are early arterial enhancement compared to the adjacent parenchyma. Venous is still slightly hyperenhancing, but not as well defined. And then on delayed, it is isoenhancing. This is compatible with a hepatic adenoma. It had rapid enhancement on arterial phase. Sometimes you can have a centripetal enhancement. Portal venous phase and late venous phase, it can kind of be a mixed bag. You have hyperenhancement or isoenhancement, but that's typically what you'll see with hepatic adenoma. And this patient had a 1-year follow-up with contrast, and it was stable 1 year later. And then 2 years after that, they had another just right upper quadrant ultrasound to evaluate stability, and it's been stable ever since. So case 4, a 16-year-old male with past medical history of leukemia, follow-up of an indeterminate lesion seen on CT. A CT abdomen pelvis was performed on this patient for concern for infection. And we see this heterogeneous lesion in the liver. And it's kind of right by the falciform ligament, and it's hypodense, but there's also looks like there might be a central hyperdense area. So, this definitely needs further workup in a patient with leukemia. Ultrasound shows this irregular area that is hyperechoic and possible some small amount of internal vascular flow. Contrast ultrasound was recommended. And this is a video right after a contrast administration. Here's the lesion. And as you can see, right away, it's isoenhancing to the adjacent parenchyma. Some still images of the different phases of contrast. On arterial phase, once again, it's isoenhancing. I pointed it out on the grayscale because we can't see it on the contrast image. So isoenhancing on arterial, venous, and delayed phase. The focal fat is the diagnosis. That is the only thing that will be isoenhancing on all 3 phases. Case 5, 12-year-old female, past medical history of disseminated low-grade astrocytoma, also hepatic steatosis and fibrosis. Liver lesions were seen on chest CT. This patient got a chest CT for evaluate for a fungal infection. We see these hyperenhancing, ill-defined lesions within the liver. Point out a couple more. These were new compared to her prior imaging. Here's a cine clip of just a grayscale ultrasound. Ultrasound was recommended. You can see these really irregular hyperechoic lesions. You couldn't really see them very well on the curved probe, but there's just a bunch of punctate hyperechoic lesions throughout. So next, a contrast ultrasound was performed. This is on arterial phase. Initially, since they were hard to see on curved probe, and there were so many of them, the first injection was done on a curved probe and just kind of as a screener of the whole liver to see if there's any lesions that appear hyperenhancing or more so even washing out early. So in the curved probe, you can see it's right after contrast administration and no focal lesions are seen. And you can see the technologist is kind of scanning back and forth, looking for something that might show some abnormal enhancement. And then the delayed phase, which is even more useful because something that might hyperenhance pretty quickly, you might miss, but on delayed phase, if it washes out early, that will persist. So on delayed phase, this was done to see if there's any early washout of any lesions, which none were seen. Excuse me. On a second injection was performed with a linear, since we could see a few lesions with the linear probe. And even though there's increased bubble destruction, wanted to see if any of these lesions, since they're so small, did hyperenhance with just focus on them. And as we can see, there's a couple hyperechoic lesions scattered within the liver, and there's no abnormal hyperenhancement on early arterial phase, and there's no early washout on venous phase. And I'll show some stills from these images. So this is an arterial phase or early arterial. We can see these hyperechoic lesions. There's no abnormal early arterial enhancement. This is a little bit later arterial phase. It's right at 20 seconds. We can still see our hyperechoic lesions in the liver, but there's no abnormal enhancement. And on venous, there's no early washout or on delayed as well. So as a lesion that is ISO enhancing on arterial phase and also on portal venous and late venous phase, this is in the background of hepatic steatosis and fibrosis and liver injury. As you can see, you know, this patient does have a nodular liver. This is compatible with a regenerative nodule or regenerative nodules because she had numerous of them. Case 6, a 10-month-old female with past medical history of trisomy 18, congenital heart disease and chronic lung disease, found to have a hepatomegaly with liver lesions, or a liver lesion. The ultrasound showed this heterogeneous lesion with internal vascular flow and some anechoic areas internally. This patient was in the ICU and very unstable with her heart disease and lung disease. Therefore, she couldn't go to an MR just for primarily her respiratory issues. So we were able to actually bring the ultrasound to the ICU and do it at bedside. So that's another big benefit of contrast enhanced ultrasound to evaluate the liver. This is a video right after injection. We see the heterogeneous mass. And we see the mass filling in. And we're at 30 seconds. If you're never quite sure what phase you're at, there should always be a clock. The sonographer should always start a clock so you can look at the timing to kind of help guide the phase. So here are some still images because, you know, that went pretty fast and it was kind of hard to tell what was happening. But on arterial phase, you can see that it's hyperenhancing compared to the background parenchyma. And on portal venous phase, you can already see that it's starting to wash out early. And on delayed phase, it's nearly completely washed out. So this is the most concerning finding on contrast enhanced ultrasound when you evaluate the liver. If you see anything that's hyperenhancing, whether it's hyperenhancing throughout, or in this case, it's heterogeneously enhancing, sometimes you might just have a little bit of peripheral enhancement. And then once it starts washing out on portal venous and late venous phase, this is concerning for malignancy and further workup is required, whether, you know, if the patient's stable and can get an MR, or if they just want to go straight to biopsy, this is where you have to start raising the concern. And this is proposed to likely represent hepatoblastoma. Unfortunately, the patient was too unstable to undergo a biopsy or treatment. The next case is a 21-month-old male with past medical history of hepatoblastoma, status post a trisegmentectomy with rising AFP post-therapy, and it wanted to follow up on new lesions seen on MR. This is a CT at time of diagnosis of hepatoblastoma, so you can see that this patient had quite large heterogeneously enhancing lesions. The post-therapy MR is showing these ill-defined new T2 hyperintense lesions after their surgery, and they were new after finishing their therapy. Kind of pointing them out there. And then post-contrast showed some additional, maybe slightly peripheral enhancement, but might be early washing out lesions in the liver, and then same with this heterogeneously enhancing lesion. So since the MR was kind of indeterminate, ultrasound was recommended. Here are a couple examples of these lesions. They're hypoechoic, there's some vascular flow, they're kind of scattered throughout. The video clip after injection of contrast. We see it filling in. And then it's already kind of washing out pretty early. And of course, I have stills. From arterial phase, you can see that there's this subtle, very early peripheral enhancement right at like 9 seconds. And it's hyper enhancing compared to the parenchyma. But then on venous phase, you can already see that there's very early washout. And on delay, there's even more so of a washout. Since there's so many lesions, a second injection was performed to evaluate other lesions and kind of did sweeps. And on the delays, it demonstrated additional lesions that showed more washout. So once again, with early hyperenhancement and then early washout on both phases, this is concerning for malignancy and ended up being hepatoblastoma recurrence. So in summary, contrast-enhanced ultrasound has many advantages over cross-sectional imaging for evaluation of liver lesions. It's helpful in the workup, as well as screening or as a problem-solving tool. And recognizing the enhancement pattern of these different lesions is really helpful and can help make a diagnosis, and as also just really help guide treatment, intervention, and also follow-up. And thank you for your time. And I wanted to thank Dr. Inapindi and Dr. Back, who helped me with provide some cases.
Thank you, Dr. Dennis. We do have a couple questions in the question and answers. The first one is, thanks for the great presentation. From your experience, how do you usually overcome the limitations related to the underlying background liver disease, which can affect the quality of focal liver lesion detectability? Do you think that modulating tumor flow can be one approach to improve the contrast between the surrounding tissue and tumors? Thank you so much.
I would think, I apologize, I just need to turn up my volume. I think having a cine clip, so I'm looking. I think having a cine clips is really helpful to go slower and just try to guide the background, but it definitely makes it really difficult. Honestly, I don't know a lot about the modulating tumor flow. I don't know if one of my colleagues has an opinion on that, if that would be helpful. I would think so, but.
Can you hear me?
Yes.
If I can chime in, I think that even in the case of tumor and you have background hepatic disease, hopefully the enhancement pattern of the tumor will be different from the chronic changes and associated perfusion of the hepatic parenchyma. And there are clear, in the setting of adult hepatic tumors, there are clear guidelines about, the washout patterns specific to tumors. And I would assume that a similar, rule would apply to pediatric liver tumors. In terms of modulating tumor flow, if you could expand on what that means. I'm not sure, if you're referring to post-interventional, or is this related to tumor therapy? Yeah, not sure about what that means.
And I agree. I feel like most of the lesions that I've seen that have background liver disease, there are distinct differences in enhancement, and usually they follow the typical pattern, especially in malignancy.
Okay, so we'll wait and see if he follows up on what Dr. Huang had asked, but we'll move on to the next question. The next one says, hi, is there a criteria to choose which lesion to assess with CIUS in cases with multiple liver lesions that can be difficult to get in a single image?
There There isn't a specific criteria. If there's multiple lesions, the best one to pick is obviously a larger lesion, but more so the best imaging window. You know, if you have one by the dome and the kid's breathing quite a bit, you probably don't want to pick that one because you're going to miss the image as they're breathing in and out. So you want to make sure you pick one that has a really good field of view. And then if it's a follow-up or, you know, something that was incidentally seen on other imaging, maybe looking and seeing, is there a lesion that already looked concerning? And going from there. That's also where there's so many liver lesions that it's helpful to maybe do a first test injection to scan throughout the liver and see if there's something that's early washing out. Then you're like, okay, well, now we'll do a second injection and focus on that one. And so sometimes it's helpful when there's so many liver lesions to kind of do a test injection and kind of see if something stands out initially. And if not, then just focus on a single one, maybe the bigger one, and then follow that throughout. But you can definitely, that's when using a couple injections is very helpful.
Okay. Can you evaluate more than one liver lesion during exam? Oh, did you just?
Yeah.
You didn't
I basically just
I'm sorry.
that one.
I'm
Yeah.
sorry. I was going through a couple questions that were given to me. What enhancement pattern is the most concerning for malignancy?
The most concerning one is just the two cases that I showed were the early hyperenhancement, and to remember that it doesn't always homogeneously hyperenhances. Sometimes it's heterogeneous depending on the contents, if it's necrotic. Sometimes you might just see very early peripheral enhancement or hyperenhancement, and then the key is the early washout on venous and delayed phases.
Thank you. Also, in your experience, have you had an overall successful interpretation compared to the other modalities using CIUS?
Yes. By actually making this lecture, I looked up a lot of either pathology reports or follow-ups, and we're pretty accurate. Sometimes, just like in MR or CT, sometimes there's indeterminate lesions. And on contrast ultrasound, sometimes you have indeterminate lesions where they don't follow the book, and either they require follow-up or they do get a biopsy. And either, it's some diagnosis that's out of left field. I've noticed our malignancy ones are, they're pretty accurate.
Okay, and what are the average number of injections for each lesion that we use?
Honestly, it just depends. If there's one lesion, you just need one injection, and you can, because you're focusing on that one. If there's multiple lesions, especially in a diseased liver, I would say at least two. I would say usually at least two. If there's multiple lesions, it's usually two. Sometimes if there's a few concerning lesions, up to three, but you have to make sure you don't go over the max dose.
Okay. Well, thank you very much for sharing your presentation. We're going to move on to our next presentation. I'm going to ask Dr. Wang to unmute her microphone and talk to us about how we utilize CIUS of the brain and bowel in newborns.
Thank you very much. Good morning, good afternoon, good evening, depending on where you are. I'm so happy and privileged to be sharing this talk. I'd like to personally thank the CPCU team, which has done a tremendous job of pursuing its goals of education and raising awareness of contrast, which is truly, truly useful for children. In this talk, I would like to share about initial experiences in the application of contrast ultrasound in neonatal brain and bowel. I'm a pediatric radiologist here and also the director of neonatal imaging. These are disclosures related to my contrast enhanced ultrasound work. So here, I'm going to talk about current and emerging applications of brain and bowel contrast ultrasound. So first, how do we do brain contrast ultrasound? So there are 3 open fontanelles, and one of them is anterior fontanelle, which you can see on the picture. And the others are posterior fontanelle and mastoid fontanelle in infants. And these are pretty much open, windows, acoustic windows where the bone hasn't formed and fused yet. And so these serve as very, very nice acoustic windows for infants. And how we perform it is we put the ultrasound probe directly on that fontanelle, and we inject contrast agents through a peripheral IV, which you have listened into, and then we simultaneously image the brain. So what can be gained from brain contrast enhanced ultrasound? Well, if you can see on the left side, what you're seeing is a contrast ultrasound image of the mid-coronal brain. And so you're supposed to have basal ganglia here, frontal horns, and the cortex. And the same plane is shown on the right bottom corner as the MRI image. Now on the right side, you have the grayscale correlate. So you're imaging the same plane. What you can see in the early wash-in phase of this scan is that the basal ganglia really looks different. And normally the basal ganglia in infants is very avidly enhancing, and you can see that. But it also has a certain shape. And the cortex at this phase of enhancement should also have some more bubbles than you're seeing. And so these are some of the subtle things that you'll notice when you're familiar with normal brain ultrasound, contrast ultrasound. And this was an infant with hypoxic ischemic injury. And sometimes on grayscale, this is not as evident as you can see on the right side. You are not sure if this is due to technique or the window settings or the probe itself, and it can be very challenging sometimes. In these cases, the perfusion patterns and alterations of that can inform you and enhance the diagnostic accuracy. So currently, as you've heard, Illumason is approved for 3 specific indications. One is the heart, opacification of the heart chambers. The other is evaluation of focal liver lesions. And the last one is vesicular ureter reflux. Brain contrast ultrasound is off-label. However, it's important to note that over the years in Europe, it's been approved. The contrast has been approved for children for a long time. And in fact, in over 1,000 children, brain contrast ultrasound has been performed at children and adults. And some of the indications include stroke, hypoxic ischemic injury, and brain tumors. So it is not so new in a sense, but quite new in the US in terms of regulatory approval. Just know that these are very small, as you know, 2 to 3 microns, which means that we'll be able to see microvascular flow dynamics in the brain. And that's the huge advantage of contrast ultrasound over other modalities. So why do we perform brain contrast ultrasound? Why are we interested at all? I mean, we have portable CT, we have portable MR, we have MR, which can yield very advanced information about brain health. Well, I would like you to take a look at these 2 pictures and think about how difficult it is every day to transport these infants and get the support staff to be able to safely perform these advanced tools. And it's really hard, especially in the intensive care units. In that regard, I think, brain contrast ultrasound provides a lot of advantages. Most important of all, it can be done at bedside and provide functional information. And when I say functional information, for decades, we have been stuck with grayscale anatomic information provided on grayscale ultrasound. And we have limited macrovascular flow information from Doppler. But now we are getting to the world of microvascular flow. And microvascular flow is very, very important in that some of the changes, macroscopic tissue changes, occur first at the microvascular flow. So you're, in a sense,
not only improving the diagnostic accuracy, but actually studying and assessing and detecting some of the earliest changes preceding macroscopic tissue changes. So here, this is a coronal plane through the brain. It's a mid-coronal plane, and you can see that the bubbles, as you can see, tiny, high intensity foci kind of come in slowly and kind of light the brain like a light bulb. So the question is this normal? Well, in the context of what I shared before, not so much, right? Because you don't see the avid basal ganglia. Let's take a look again. You're supposed to see the egg-shaped basal ganglia in infants, but we're really not seeing it. We're seeing the perfusion in all of the brain. So what's happening? Well, this was a case of diffuse white matter injury. So what was happening was that there was reperfusion process to the injured white matter such that the avid basal ganglia, which are supposed to perfuse and stand out, is not standing out because the rest of the brain is perfusing a lot. So that was what was happening here. So let's take a look at what the normal brain perfusion looks like. Well, there we go. There's the avid basal ganglia and prompt wash-in of contrast through the rest of the cortex. And what you'll notice is pretty prompt washout of contrast. And that's important because the timing of these wash in and wash out has implications for diagnosing brain injury. If you have actually delayed washout of contrast, that could mean that the brain is injured. And I'll show you an example of that later in the slides. So how do we perform brain contrast ultrasound? Well, I've shared with you that you utilize the fontanelles in infants. Actually, as the child gets older, you could utilize the temporal bone as the acoustic window, and amazing works are underway to resolve in super resolution some of these microvascular flow dynamics through the temporal bone, even in adults. So that's exciting direction. But here, what is shown at the top is the coronal brain, and the yellow is the frontal horns, the red is the basal ganglia, and you see the temporal lobes, the white arrows, and the frontal cortex is the orange arrows. And in time 0, you can see there's no contrast. And as you progressively, increase in time, you can see that at around 15 seconds in this infant, you achieve the peak enhancement, and you have a fairly prompt washout. And by 25 seconds, you have begun moderate washout at that point. So this is the kind of case that demonstrates that the wash in and wash out timing and recognition of that is very important for diagnosing brain injury. You're going to notice that unlike the prior cases, especially the normal one, look at the perigyral flow. It's very, very avid. And I'm sure we have passed 15 seconds by now, and still the perigyral flow is very, very avid. So the washout is very much delayed in this infant, which is interesting because on grayscale, it's hard to know what's going on down in the brain and understand exactly what brain health is for this infant. And on top of that, on MRI diffusion, nothing was ischemic. Now, interestingly, a couple of months later, this infant developed marked hydrocephalus and marked encephalomalacia. I think that this kind of highlights the fact that microbubbles are not only important for diagnostics, but the way in which they perfuse, and if you actually derive quantitative parameters, that may potentially aid in the prognostication of these infants with brain injury. Of course, this warrants further investigation, and these are a few case examples, but certainly very promising utility of microbubbles. Now, beyond hypoxic ischemic injury, which is the main indication that I shared, we can use this technique to diagnose and monitor vascular malformations in the brain. So this is a sagittal plane through the brain, and what you're seeing is all this coil artifact in the vein of Galen malformation, coiling. And in this case, I think it's very important and useful because the clinical team wanted to evaluate residual flow in the brain vessels post-coiling. And I think that was very important to them because they can determine whether, brain is receiving enough flow, if they need to go in and coil again, except if you see this picture, probably not coil again because the whole coil is in the vein of Galen malformation. The left side is the sagittal T2, showing very, very large vein of Galen malformation, AVM, in the brain. And on the right side is the static fluoroscopic image showing marked coiling within the lesion. I wanted to share this case because this demonstrates that contrast can be a useful troubleshooting tool that can be readily integrated into clinical care. This is an infant, full-term infant, presenting with jerking movements of limbs. The clinical team was very concerned that there was a potential abnormality in the brain. We performed grayscale ultrasound, and these are coronal slices through the brain. And I want to give you a moment to kind of recognize any focal abnormality that you may be able to see here. Okay. Now, this is a near field image of the coronal brain, and what you're seeing on the right is actually called microvascular imaging technology. It's a form of advanced Doppler technology that's integrated into most commercial systems. This is, I would say, simply put, a step up from traditional Doppler, where you're able to suppress the static noise and bring out the slow flow of any organ. And what you're noticing is that there is a suggestion and actually the presence of asymmetric perfusion in the brain. Most notably, the left side is more perfusing in the deep medullary veins, maybe the perigyral vessels. But we're still not sure what may be going on. Is this true? Is this artifactual? Well, we try to confirm that at the bedside by injecting contrast, and voila, there is marked perfusion of the left frontal lobe, and posteriorly you're not seeing that effect, so we know that it's isolated to the left frontal lobe. And this is related to reperfusion process post ischemia. So very, very obvious on contrast ultrasound, and a useful troubleshooting tool where if grayscale ultrasound is equivocal, microvascular imaging suggests that there is a focal abnormality, you confirm with this, and this can really expedite care. So this is a left frontal infarct. I want to kind of inform you of the advancements in super resolution technologies using microbubbles, and also parallel advancements in Doppler technology, which I think can be combined as adjunct tools to ultimately improve our diagnostics in infant brain and help guide management better than what we're doing now. On the left side is actually half of the pig brain, and you can see all these microvessels down to, in fact, less than 10 microns. it's interesting that, when this was initially started, this seemed very, very novel, but now this technology is being developed at the commercial level. They're trying to, promote particle tracking and advanced technology. And that's very exciting because all of these tools are up and coming and potentially maybe very helpful for diagnostics. Now, on the right side, just to explain, this is a sagittal plane through the infant brain. And what you're seeing is all these, first of all, ACA, anterior cerebral artery, and its branches kind of pulsating. You can visualize it real time. I mean, that's impressive because some of the pulsatility alterations are directly related to brain pathologies, and you can visually see that. So now I wanted to move on to neonatal bowel contrast ultrasound applications. Admittedly, this is a topic that needs to be further explored. However, what I've found very, very useful in the clinical setting is actually monitoring bowel perfusion and assessing bowel ischemia. And there are several cases, and one of which I'll show was very, very helpful for clinical management. These are some of the potential indications that this technology can be developed for, and I'll show you some examples. So this is an infant with surgically proven neck, and what you're seeing is all this aperistaltic, dilated, hyperemic loop of bowel, and you see also some loops of bowel that's dilated and not enhancing as much. And then in the middle, you're seeing some loops that are not as enhancing, but enhancing more than some of the loops that were not enhancing. So I think this is interesting because, first of all, this infant turned out to have about 20 centimeter length ischemic bowel. And what I wanted to, and it can be challenging to kind of identify the ischemic bowel, especially if you don't have the grayscale next to the contrast image, because on the grayscale, you can appreciate which is bowel, which is not. But if you just have contrast image, it may be challenging to identify the ischemic bowel that's not enhancing. So I found that side-by-side image, just like this, is very useful for identifying bowel loops that may be ischemic. And one of the important lessons that was learned through, a couple of cases of neck that, we've scanned is that neck is a very spatially heterogeneous disease where you don't have a case where you have, ischemia and the rest of the bowel looks the same. No, but it's actually spatially heterogeneous where you have this loop by yellow arrow that has minimum enhancement. All the while juxtaposed this loop is a very hyperemic loop. So even within the same abdomen, you have this different perfusion patterns, and you can potentially identify kind of the disease progression and the severity of the disease. And, more work has to be done here, and specifically understanding the spatiotemporal evolution of perfusion in necrotizing enterocolitis. I think that's a work in progress. We do have 2 INDs, investigational new drug applications, and clinical trials looking at the contrast-enhanced ultrasound patterns in hypoxic ischemic injury as well as necrotizing enterocolitis. So hopefully we'll be able to learn a little bit more about the utility of contrast in this case. But what is clear is the utility of contrast in detecting bowel ischemia. And this is one of the cases that I really wanted to show. So this on the left side is a grayscale image of the infant abdomen. And on the right is a color Doppler overlay. You have some flow, whether it's in the mesentery or whether it's in the bowel wall, it's very unclear. And why? Because the infant was connected to an external oscillator. So what's happening is that the oscillation is creating all these Doppler artifacts. And so it's really, really hard to detect bowel ischemia in this case. Well, the clinical concern was very, very high. The infant was not doing well. And I think whatever we could provide, they were appreciative. So we went up and performed contrast ultrasound at the bedside. And what you're seeing actually is non-enhancement of the entire bowel. And that was impressive, to the point that we were questioning our, technique, but what you're seeing is non-enhancement, absolutely nothing whatsoever. So what happened in this case was we saw no enhancement. We let the surgical team know, who was at the bedside with us. The infant went to OR, total bowel ischemia was confirmed. And unfortunately, the outcome was not good, understandably, and the infant passed away not long after the exam. So in summary, brain and bowel contrast can be valuable complementary tools to grayscale and color Doppler ultrasound. And I think most importantly, it is an adjunct tool, a very useful adjunct tool for infants whose situations and critical state don't make them eligible or easy candidates for advanced tools like MRI or CT. And one of the things that I really want to highlight is that it does provide functional information that the other tools don't provide. And so that's one of the advantage of using and advancing this technology. And of course, we're humbled because there's a lot more to learn, and further exploration of its clinical utility is very much warranted. Thank you for your attention.
Thank you so much, Dr. Huang, for that outstanding presentation. You showed so many extraordinary examples, both combining your research and your clinical experience in these areas. Can you talk a little bit about the cases that you've done clinically, how you engage with the NICU in particular for these examples, and how you decide whether to proceed with contrast?
Yeah, that's a great question, Sue. I think for the, these are the cases that some of them are sort of equivocal based on standard of care. So there are two indications for which we perform contrast ultrasound. We perform as part of research and we perform as part of clinical care. For contrast ultrasounds that are performed as part of clinical care, it always is performed when there's an equivocal finding or something that contrast ultrasound would actually enhance the diagnostic accuracy. So for instance, I've showed a case of a stroke. There are also cases of, very equivocal lesion that, the multidisciplinary team kind of gets together, for instance, and we've done this with IR with Dr. Cahill, where we have a lesion that even after angio is a little uncertain. And after performing contrast ultrasound, we saw very, very interesting, connection to the leptomeningeal vessels, such as that, where contrast ultrasound can really aid in the diagnostics.
So that was actually a nice dovetail into a follow-up question, which is when you're on the forefront and seeing things in a new way for the first time, how do you make clinical decisions, and do the teams that you're collaborating with feel comfortable moving forward, perhaps without being able to confirm by MRI or by another modality where we've become more comfortable with these diagnoses?
Yeah, that's a great question too. In the case of stroke, for instance, the infant was not stable enough to go to the MRI after the contrast exam. For whatever reason, the portable CT was down. And so there was a delay in MRI confirmation, but together with EEG, the neurologists were pretty comfortable that there was a left frontal stroke. So in that sense, I think that gave them the confidence in the diagnosis without performing the advanced tools. And the management was not going to change anyways, because of the supplemental findings of the two modalities. I think as we kind of improve our understanding and experience of this technology, hopefully this alone will stand as a diagnostic test for a lot of diseases. For now, we are supplementing with advanced tools in most cases. However, what's the advantage of this is that we kind of expedite care. If we find some abnormality on the brain contrast or bowel, then you really expedite care. You can actually expedite the acquisition of MRI or the grouping of multidisciplinary team to discuss about the infant. So in that case, I think it has a lot of potential beyond just a sole diagnostics in guiding management.
Excellent. For the cases of neonatal bowel and the question of neck, do you see contrast ultrasound becoming part of the routine protocol in the future, or as a secondary step for troubleshooting what we see on grayscale?
That's a great question too, Sue. So right now we are limited even in our understanding of grayscale and Doppler in neck. So there's a lot of work to do. And that's the same thing goes for contrast ultrasound. What is useful that I've found for sure at this moment is that the contrast can identify ischemic bowel. But as we kind of gain more understanding, we'll be able to kind of utilize and balance all these modalities to understand where contrast fits into the diagnostic workup and prognostication of these infants. For now, I don't have a clear answer. However, if we find that there are spatial temporal patterns specific to surgical neck, then I think it warrants really integration of contrast into the disease workup.
Thank you. Thank you for the extraordinary work that you do. Reminder to everybody who's participating to please put your questions in the Q&A section. We are running ahead of time, so if you have questions from other presentations or for that to come, we can get to them toward the end. Thank you very much, Dr. Huang.
Thank you.
Now I would like to welcome Dr. Vatsky to unmute his microphone and share his screen, and he will take us into the world of interventional radiology.
Thank you very much, Dr. Back. So my name is Seth Vatsky. I'm a pediatric diagnostic and interventional radiologist and associate director of patient safety and quality for the IR section here at CHOP. I'd like to begin by thanking the course committee for the invitation to share our section's experience with intravenous contrast enhanced ultrasound in the pediatric IR setting. I'd also like to thank my colleagues on CHOP IR, in particular Dr. Cahill, Dr. Krishnamurthy, Dr. Srinivasan, Escobar, and Accord for sharing their experience and case examples for this presentation. I have no relevant financial disclosures, but as we have previously discussed, the use of intravenous ultrasound contrast agents for interventional procedures has not been approved by the FDA. I am also getting over a little bit of a viral infection myself, so I apologize if I cough in both for my voice during the course of this presentation. So my objectives today are to discuss the benefits of using intravenous contrast ultrasound in pediatric IR, provide examples from our own experience and the literature, and review our current workflow and some pitfalls in the use of contrast enhanced ultrasound in the IR section. I have indicated some kind of what I think key points by this little bubble indicator. And additionally, I included this TLDR, or too long didn't read or watch slide, which has a culmination or a cumulative appearance of the critical items that I'd like to convey to you during the course of this presentation. There's a growing body of literature on contrast-enhanced ultrasound and IR applications. I provide links for 3 high-yield articles describing the technique and applications of contrast-enhanced ultrasound. The top one is a more general applications article for contrast-enhanced ultrasound. The second one is a radiographics article from 2020 by Malone and his group. This last one is actually a publication of our own section available in the 2021 Pediatric Radiology Supplement on Contrast-Enhanced Ultrasound. So first, I'm going to go back into contrast-enhanced ultrasound basics and talk about it from the perspective of interventional radiology, and then also follow up with reinforcement of some of the critical points that were presented earlier on today. So as radiologists, we are all familiar that with the exponential improvement in the quality of ultrasound imaging since initial clinical use. We've integrated conventional ultrasound guided procedures as a critical component of our IR practice, and that's because it provides excellent temporal resolution without a radiation cost. It also allows non-conventional plane imaging, allowing flexible needle path planning without time-intensive reconstructions. It's easily accessible, it's cost-effective, and it's portable, allowing the use of ultrasound at the bedside. Now, contrast-enhanced ultrasound is valuable in its increase in contrast resolution. It allows better tissue characterization and including tissue perfusion and distribution. And as we've heard in Dr. Natulia's lecture earlier today, the contrast agents have a very favorable safety protocol, avoiding the traditional concerns about renal toxicity with our iodinated contrast or gadolinium deposition. Now, as already been talked about earlier today, the contrast-enhanced ultrasound is a highlight gas sealed in a lipid or protein shell. It allows image contrast due to the differential impedance between the gas and liquid. And when it's insulated with a low mechanical index, that shell deforms and produces harmonic echoes, which we can detect. Now, we have to be careful about those high mechanical indexes because those can end up rupturing the shell. It remains in the blood pool until rupture and dissociation with exhalation of the lungs, which is key in interventional radiology because it is truly a blood pool agent. There are numerous agents on the market, and although pediatric dosing is available for a couple of them, the only one that's FDA approved for pediatric indications is going to be Sonaview or Lumason. Numerous vendor-specific packages for contrast-enhanced ultrasound are available. Not all pre-existing probes are contrast-enhanced ultrasound compatible, so it is important to be aware of probe compatibility and look at your current available probes in interventional radiology when integrating it into your practice. You may actually have to borrow ultrasound units from your ultrasound department if needed. You want to maintain that low mechanical index. You want to be able to make sure that your focal zone is set to the proper target tissue and depth. You want to keep your gain adjustment relatively low, especially in that pre-contrast setting to make your kind of a low level on your contrast enhanced study. And you want to think about your dynamic range. With wider range or high dynamic range, that's going to be better for depicting varied degrees of enhancement, such as soft tissue characterization. While with a narrow window, you're just going to accentuate vessels, especially in areas of low perfusion. And why is that important? You really remember in interventional radiology, we may not be functioning in the presence of a full ultrasound technologist. We may be working with our IR technologists. So we have to take a greater part in our pre-procedural setup as far as our ultrasound imaging. If we either get the probe wrong or the settings wrong, well, that can lead to increased potential dosing with our IV contrast agent that can lead to increased shadowing, which would cause us to increase our mechanical index, which has this feedback loop that results in bulb destruction, ultimately very suboptimal imaging. So we really want to try and lean towards utilizing those low frequency curved probes wherever we can. And as Dr. Dennis touched on, is selectively using our linear probes when a curved probe is not appropriate for visualization. Additionally, in specific instances, we may consider intracavitary probes. We use that more frequently with intracavitary injections, which I won't be touching on today, but certainly is an area of our use and practice currently as well. So we're going to move on and we're talking specifically to the IV contrast-enhanced ultrasound in interventional radiology. So 3 agents available in the United States, although only one has a pediatric FDA IV indication and dosing protocol, and that's Lumason, which is 0.03 milliliters per kilogram, up to 2 mLs for echocardiography or 2.4 milliliters for liver. So generally we go to that higher dose in our IR practice. And you do have the ability to repeat your dosing to repeat or better visualization of any target structure. This is our general setup. Here I've got my colleague, Dr. Srinivasan here, who's imaging this patient's vascular malformation with ultrasound. Our technologist, Angela, who's currently operating our ultrasound, and our nurse, Melissa, who is currently working the patient's IV access. This is just a zoom-in view of our split-screen contrast-enhanced ultrasound, making sure that we, in this case, are using a linear transducer probe, and we've nulled out that contrast-enhanced study or side of that screen to keep the gain at an appropriate level. I think as Dr. Back had touched on earlier on, we tend to inject our contrast in line to the patient with as little intervening devices as possible. And then we have a side hookup on a three-way valve with our normal saline. And here you can see that depicted in this patient with the saline flush on the side and our contrast in line for administration through the IV with very minimal intervening connecting tubing. So two critical characteristics for contrast-enhanced ultrasound is the small size of the bubble that allows it to pass through the capillary system, and then also what I like to call the bubble life cycle, with the ability to continuously visualize through target tissues through the arterial portal and portal venous phases. Because IV contrast-enhanced ultrasound is a blood pool agent, the presence of bubbles outside the vascular space can be a sensitive indicator of hemorrhage and helpful in identifying peritoneal and genitourinary hemorrhage. So this is a chart adapted from Malone's article and provides a nice review of the current applications of contrast-enhanced ultrasound in interventional radiology. So here's our current interventional applications in contrast-enhanced ultrasound, both in pediatric and adult interventional radiology. We most commonly use it for percutaneous biopsy guidance. We can use it for guidance in ablation assessment. We can use it to define complex abscesses. We can use the assessment of lesions following transcatheter hepatic interventions such as TACE or TARE. Again, that is more common in the adult population than the pediatric IR setting. We use it for the assessment of the end organ and perfusion, pre and post angiography, the evaluation of TIPS, more common in adults, but also present in pediatric population, and then a confirmation of venous catheter position or extravascular location. Again, the benefits of IV contrast-enhanced ultrasound include the favorable safety profile, the portability, the ability to perform repeat dosing, there's limited motion artifact, and then even with hardware, a lot of times you can reposition your ultrasound probe around that area, and the absence of renal toxicity. Obviously, we've talked about some of those known drawbacks, primarily anaphylaxis. Although it's rare, it is a known risk. And in interventional radiology, access to critical response devices should be on hand, but you want to make sure your team is prepared for it. There certainly is an additional cost of contrast-enhanced ultrasound, both financially and involving procedure time, but this can be offset by the improvement in diagnostic accuracy and early identification of complications and increased procedural confidence. And as you use it more in the interventional setting, it becomes more efficient and less time consumptive. So I've highlighted some of the indications that are commonly used in pediatric IR and will provide examples through the remainder of this presentation. So percutaneous biopsy is our most common indication for ultrasound contrast in the pediatric IR department. It can assist with assessment of the solid lesion in the liver and kidney. The agent allows continuous characterization of lesions and creation of time intensity curves for lesion assessment and has been shown to increase diagnostic accuracy in the adult population, especially in lesions that are less than 2 centimeters in size and obese patients. So for example, this is a 4-year-old male with history of heart transplant with newly identified hepatic and splenic lesions on PET scan that were concerning for lymphoproliferative disease. While the dominant nodule is easily discernible on grayscale ultrasound, additional smaller nodules had variable ultrasound characteristics and were more difficult to confidently identify. You can see this more subtle lesion in the right upper image that shows only mild hypoechogenicity in comparison to the background liver. Now, contrast-enhanced ultrasound really improved the visualization of this lesion, and we felt very confident being accurate with our sampling under general anesthesia. So 2 lesions were sampled, and the resulting pathology was EBV-associated smooth muscle tumor, which was an unexpected finding. This is a rare tumor of uncertain biological potential that occurs in immune-suppressed HIV and post-transplant recipients. So this case shows the benefit in lesion location, and it also shows the value that localizing that more subtle, smaller lesion and sampling it was able to confirm that not just the single lesion, but the multiple lesions were all related to the same underlying pathology. In addition to lesion identification, component targeting is a critical use for contrast-enhanced ultrasound. So this was a 10-year-old male who presented with a right hepatic mass with a differential of hepatoblastoma, hepatocellular carcinoma, and undifferentiated sarcoma. On radiograph, you can see the enlargement of the right hepatic contour. On ultrasound and post-contrast axial CT, you can see the heterogeneity of the lesion with patchy peripheral enhancement. Now, on MRI examination, you can see that the area does restrict with T2 hyperintensity, is somewhat gelatinous in appearance, and there's still that peripheral enhancement, but no central enhancement. So we proceeded to go on ultrasound-guided biopsy after obtaining the MRI. And while we discussed the potential use of contrast-enhanced ultrasound for the biopsy, our biopsy yielded pretty well-organized cores. And we deemed it that it was unnecessary to do the CEUS, sent assessments of pathology, who initially thought it was going to be sufficient. Unfortunately, though, all 9 cores came back as significantly necrotic, and they couldn't make a diagnosis based on this percutaneous biopsy. So therefore, we ended up having the patient return to interventional radiology and utilize contrast-enhanced ultrasound. At biopsy, we were able to target the peripheral contrast-enhanced lesion and confirm the diagnosis of undifferentiated embryonal sarcoma. So this was patient was staged at pretext 2, and a right hepatectomy was performed. The patient is now 3 years out from resection and doing quite well without evidence of disease recurrence. This was a 3-year-old male with new hepatic mass and a history of autism. He presented with capsular rupture and was referred to IR for biopsy. On grayscale ultrasound, the extensive areas of necrosis were difficult to appreciate following contrast administration. We were able to target lesions that were well perfused and normal background for comparison. The patient was diagnosed with hepatoblastoma, was staged at pretext 2R positive, and proceeded to neoadjuvant therapy, partial liver and mass resection. And he is now 1 year off therapy without evidence of recurrence. Contrast-enhanced ultrasound can also be used as an adjunct technique to assist in post-procedural management. This was a 19-year-old female with a history of severe tuberous sclerosis and mid-aortic syndrome and bilateral angiomyolipoma. She had seizures and extensive behavioral issues. Now, I had treated her AMLs previously with selective renal embolization about 2 years prior to this MRI, and there was initial bulk reduction in the AML. At that time, her inpatient admission was complicated by agitation, and as a result of the unfamiliar environment, required both physical and chemical restraint, which obviously was a difficult experience for both the patient and the family. On her 2-year follow-up of MRI, there was a new left lower lobe lesion with variable parenchymal enhancement and rapid growth, which raised the concern for recurrent angiomyolipoma versus renal cell carcinoma. So the patient went on for ultrasound and biopsy. We can see the lesion was well localized and identifiable on grayscale ultrasound. On pre-biopsy contrast-enhanced ultrasound in the blue box, the lesion rapidly enhanced, confirming more profound vascularity associated with the lesion when compared to the MRI. We performed cores from several areas of the lesion because we were concerned about sampling error. On the post-biopsy shown in the yellow box, contrast injection, we can see intralesional hemorrhage, but no evidence of contrast enhancement or spillage following the biopsy. This gave us increased confidence for post-biopsy management, and we were able to discharge the patient home after a 6-hour observation period, avoiding a potentially complicated admission. So this is an example from the literature that shows a plume of contrast material after erupting from the liver surface following target ablation. So in this case, they were able to regain hemostasis by performing an additional ablation cycle at the site of bleeding and coagulation. So if you kind of keep your eye up here in the upper left-hand side of the screen, you can see that there's a plume of contrast moving its way into the peritoneal space around the liver. See it, and they scan through. Right there is where you see it best. So contrast-enhanced ultrasound can provide a helpful adjunct in the treatment of patients with vascular malformations. This was a 12-year-old male with lower extremity vascular malformation. You can see the extensive multi-compartmental T2 hyperintensities within the leg, both superficially and a muscular component. And this was thought to be a primarily venous malformation. However, upon sclerotherapy, there was only a finite amount of abnormal venous channels. Contrast-enhanced ultrasound examination failed to show treatable targets for sclerotherapy with predominant soft tissue enhancement character and less venous pooling. So supported by these findings, we modified the primary diagnosis from venous malformation to a fibroadipose vascular anomaly, or FAVA. And the patient was initiated on sirolimus and anticoagulation and has done quite well with regression of the lesion on follow-up MRIs. So here you can see the vascular enhancement, but you don't see a lot of abnormal vascular channels and only low-level tissue perfusion here, which is much more consistent with a FAVA than it is with a venous or lymphatic malformation. So my anesthesia colleagues have a saying, sometimes the best anesthesia is no anesthesia. This is also true for pediatric IR interventions. This was a 5-year-old female who presented an acute liver failure prompting hepatic ultrasound. The Doppler ultrasound showed no flow within the portal vein, and the IR department was consulted for possible thrombectomy of the portal vein. We were a little bit quizzical on this, so we did a contrast-enhanced ultrasound at the bedside, and the portal vein did enhance, excluding portal vein thrombosis and avoiding an unnecessary transport and intervention for this patient. Contrast and ultrasound can also be helpful in TIPS patency assessment. This has been documented in the adult literature. Contrast and enhanced ultrasound improves the detection of TIPS stenoses and has a lower false negative rate in comparison to Doppler ultrasound alone. Finally, we use contrast-enhanced ultrasound for pre- and post-assessment in the setting of renal perfusion status post-angioplasty. Our hope is the enhancement curves may provide insight into procedural outcomes and prognosis, but can also be helpful in the assessment of perfusion defects following angioplasty. This was a 20-year-old female with history of neurofibromatosis type 1 and renal vascular hypertension. They presented for angioplasty with with a positive CTA, the renal artery. So her angiogram confirmed the presence of a right-sided renal artery stenosis. This was successfully treated with angioplasty, but there was development of this wedge-shaped defect, filling defect here within the right kidney following treatment. And we weren't sure whether this was related to an infarct or vascular spasm. We were able to repeat the contrast-enhanced ultrasound to evaluate the presence of the lesion 24 hours post-procedure, and the resolution of the perfusion defect spoke for it being related to transient spasm rather than a persistent infarct. So some pearls and pitfalls for contrast-enhanced ultrasound. You need to develop user experience and diagnostic confidence. The visualization on ultrasound can be limited because of sonographic window, body habitus, and you have to recognize that it has a smaller view of field of view than CT or MRI. You need to build that acceptance of the clinical surface, which I think has been a consistent theme throughout our presentations today. And there is an added cost, both financially and as far as the time dedicated to it. But again, there are significant returns on that upfront investment. It's really helpful to have pre-intervention imaging to be able to compare. It'll save you on the number of runs you need to do or injections you need to do during your procedure. You need to make sure you've got a good sized IV, and you want to make sure you rehearse and go over those roles of your technologist, your physician, and your nurse for that procedure. And then make sure you don't prepare those microbubbles too early during the procedure to have them available. You may have to re-agitate them if you're doing an additional administration, and be prepared for an anaphylactic reaction in the very rare instance that it may occur. So in conclusion, contrast-enhanced ultrasound is a useful adjunctive tool for pediatric interventional radiology. It increases localization of lesions for biopsy. It increases yield of partially necrotic targets and improves sensitivity and accuracy in the assessment of thrombosed vasculature and assessments of TIPS patency. It can also be helpful in assessing for bleeding and perfusion following angioplasty and embolization procedures. This is one, again, that summary side, some selected references. And again, my gratitude for your attention during this period. And also, again, the incredible work that the CPCU and ICUS has done in promoting the use of contrast-enhanced ultrasound. Thank you.
Thank you, Dr. Batsky. We do have one question in the box. It says, thanks for the magic presentations. Is it true measurement renal cortex during CUS? Is it true, I guess, true measurement of the, I don't know, the perfusion or?
Yeah. So again, I'm trying to understand exactly the question. I assume is, does the measurement of the cortex on grayscale match with the contrast enhanced ultrasound cortex measurement? I can't say that I definitively measured that to confirm that they are, although I will say by my experience when we're using interventional radiology that they often match quite carefully, quite well in that initial phase. But you will see that progressive enhancement into the medulla as you see progression. So it depends a little bit on your timing of your contrast enhanced ultrasound imaging and how well it matches to the traditional visualization of the cortex. And certainly I would open up to Dr. Dargay or any of my other colleagues for any comments regarding that.
Okay.
I think there was also, I guess, a question that was brought up a little bit more about use of contrast and ultrasound for renal stones as well that you had brought up. We didn't go into cavitary access, but we certainly have used contrast enhanced ultrasound when we're accessing non-dilated collecting systems. It's a fantastic way to pacify the collecting system and confirm your intraluminal without infecting creating the artifact that you would normally have with utilizing iodinated contrast in that situation. So I see another question here.
It says, thanks for the great presentation. Where do you see the potential for C-use in combination therapies to be used in clinic, for example, to enhance drug delivery for tumor therapy?
No, absolutely. Now, it's because of the United States, the use of the CAG protocols. We do not do a lot of chemoembolization here at CHOP. I think that is being developed and certainly on the frontier. But I think that contrast-enhanced ultrasound with associated drug delivery and interventional radiology's ability to get it to the target tissue is going to be a frontier in the future. So we don't have personal experience with that, but I certainly see that as an aspect of our practice in the future. And then I see this, have you used contrast to support post-thrombin injections? I personally have not. I do believe that one of my colleagues, I do recall a case, I don't recall the direct details of it, where we did use contrast post-thrombectomy to reevaluate those areas. And I certainly see that as a potential role as well.
Maybe Dr. Huang can mention some of the experimental therapeutic application she's looking into.
Oh, sorry, you were saying thrombin injection. Sorry, a little bit different there than what she was saying as far as thrombolysis. I misread that question. For thrombin injection, I haven't had to, as far as thrombin injection for occlusion of a pseudoaneurysm. I've been pretty, so far I've seen it sufficient to use a grayscale and color ultrasound for confirmation for those procedures, but certainly should be very effective if there's any question. So we often use it in these kind of troubleshooting situations. I did have one case where I tried it for a patient who had a very large hemorrhagic neurofibroma in the leg. But for that situation, the tissue detail wasn't quite what I needed to be able to rule out the pseudoaneurysm that particular patient had after post-treatment. But certainly in another patient, I think that would be a good application of it when you have good grayscale visualization.
And just to expand back on the prior question about modulating tumor flow and bridging back to here, how are microbubbles useful for theranostics, basically, therapy and diagnostics? So in terms of the tumor modulation flow, actually it was posed by one of our scientists, and it's a really nice idea. It's actually, that group has applied injection of some materials to enhance the blood flow and the differential blood flow between the tumor as opposed to the background, tissue parenchyma will be different. That's the basic idea of modulation tissue-specific modulation of flow and using that as a tool for diagnosis. So that is a great idea, although I think that even improvements in diagnostic approaches may be able to detect tumor with high enough accuracy. But I think that combinatory approaches may be useful and definitely a future direction for research. In terms of the theranostic applications, I think that the potential for use of microbubbles in delivering drugs, targeted delivery so that local regional yield is high, is very, very high. Microbubbles can encapsulate any drug agents or gene of interest, and certainly some of the work is being done at CHOP, where we've tried to encapsulate neuroprotective gas into the microbubbles and deliver it at the level of the carotid so that you have high yield release of neuroprotective gas at the level of the carotid and achieve some of the local regional yield and efficacy that's not achievable by systemic delivery. So that's a very attractive direction of microbubbles beyond diagnostics. And there are recent advancements in using microbubbles as well as ultrasound pulse to induce blood-brain barrier opening. And the idea behind that is that as the microbubbles oscillate, that creates local regional effect that can induce transient openings in blood-brain barrier, and combining that with some of the drugs that are being delivered, it can actually achieve the efficacy that's not achievable by just injecting drugs of choice. The other things that are being explored is that they actually use it as a radiosensitizing agents, where they deliver oxygen into the tumor, and after that you induce radiotherapy, then that can induce radiosensitivity. There are a lot of things that are going on which has the potential to directly translate to clinical settings. So it's very exciting because now diagnostics and use of microbubbles in the diagnostic setting is not limited to just visualizing, but I think there's a potential for combining some of the therapies to diagnostics, which is the future direction, I think.
Thank you.
All right, thank you. So now we're going to welcome back Dr. Dargay so he can give his closing statements. Thank you, everyone, for joining us today. And if there is any other questions, you can still put them in the chat box.
Thank you very much, everyone. I am so delighted to see so many attendees from around the world. It's really wonderful to have so many colleagues who are interested in pediatric contrast ultrasound modality. I want to thank all of my colleagues from the Center for Pediatric Contrast Ultrasound at Children's Hospital of Philadelphia, who have put in this fabulous webinar in collaboration with ICUS. It's really amazing to see how far we have come with pediatric applications, ranging from those on-label, like liver, but also many off-label applications, including the brain and including interventional use. So it is great to see the advancements, and I really do hope that these presentations will motivate you and help you in the application of contrast ultrasound in your clinical service, remembering, as mentioned, that the adverse events related to it is minimal, but with the awareness of anaphylactic reaction and the need for a cart around the ultrasound unit. So with all this said and done, again, thank you to the speakers and thank you to the attendees, and wish you a wonderful day. Goodbye.